Hi, I'm Mehdi Shishabor. I'm the Director of Cardiovascular Interventional Center here at University Hospitals. And today I have the honor of having Dr. Marc Pelletier. He's the Chief of Division of Cardiac Surgery here at University Hospitals. And today we want to discuss with you and have an interactive session around ECMO, both during the era of COVID, but also pre-COVID, and kind of give you an overview of our program as it relates to ECMO. So Marc, if you can please start and give us an overview, and maybe then we can go back and forth and ask some questions and get into it.
That'd be great, Mehdi. Thank you very much. It's nice to be here. So I'd like to talk a little bit about our ECMO program, and I'll do that in the context of sharing with you what it is that we do already. Within the UH system, the Harrington Heart and Vascular Institute has gotten to be a fairly big institute, and this just gives you a little bit of an idea of how many procedures that we do on an annual basis, how many patient visits that we have, the cardiac operations and surgeries that are done. And really, this map shows you kind of the scope and breadth of all the centers that we have in all the various places that we function. And the reason that's important for today's conversation is that when we're talking about ECMO, it's really a modality that we can go and stabilize some patients that are very, very, very sick. And we'll get into that a little bit more in the next few slides. This gives you a little bit of an idea of our centers, not just in Cleveland, the UH centers, but I've also put in some of the other health systems there. That gives you a bit of an idea of where we are located, so that you'll see geographically we operate and do cardiac surgery at many sites, and all of these sites have the capability and more of putting people on ECMO and stabilizing some of these patients. And that's really all part of what we're seeing here within the UH system, which is a growing program that's growing on an annual basis. So let's talk a little bit about ECMO. So ECMO stands for extracorporeal membrane oxygenation. So what that is taking somebody who's really dying either from one of two causes. It can be heart-related, or it can be lung-related. So there's respiratory failure or heart failure that can be helped by ECMO. So examples of heart failure would be somebody who has a massive heart attack. Heart function is very, very poor, and despite medications or opening up with a stent or all the things that we do, the heart is still so weak that the patient can't breathe, can't sustain good oxygen levels or good blood pressure or anything like that. And without some form of other intervention, that person will probably die. When that happens in the UH system, it's somebody who's in shock, cardiogenic shock. The other people are people who have respiratory shock. So until COVID came around, we would see that every once in a while. We saw that with H1N1, we saw that with SARS. We would even see it sometimes with somebody who has bad influenza where their lungs really get damaged, and they develop respiratory failure. So their heart may be okay, but their lungs are not able to oxygenate. And unless you do something, their oxygen levels go down and down and down, and they die. So in either cardiac or respiratory shock, one of the modalities, one of the last steps is to put them on ECMO. What ECMO means is really that you're going to take the blood out of their body, you're going to run it through a machine that's going to do two things. That machine will oxygenate the blood, and it will pump it back into the system. So let's say somebody has heart failure, severe heart failure and shock. So ideally, you would put a cannula, a huge IV, into their femoral vein. You would draw the blood out, and you would pump it back into the femoral artery. So you would bypass, in that case, both the heart and the lungs. Right. So that would be called veno-arterial ECMO. If you had somebody who had respiratory failure, their heart's okay, you don't need to bypass the heart, but you need to bypass the lungs or oxygenate the blood. So in that case, you would put a cannula, the easiest way would be in one femoral vein. It would draw out that blood that's deoxygenated, run it through the ECMO circuit, and pump it back in, oxygenated, back into the venous system. So it would be veno-ECMO. So those are the two types of ECMO, and those are the types of ECMO that we've been doing here at UH for quite a while. Yes. In fact, not just here, but we've developed an extensive shock program that our EMS teams have been involved with, I know, on many transfers, where we get calls from anywhere in the UH system. So the way that works is that we get a call, let's say we're at Portage or Geauga or St. John, somebody's in real trouble. They call a central number here. On the phone, typically we'll have, and we've been on many of these phone calls before, we'll have 3 or 4 people on, a surgeon, a cardiologist, an ICU physician, and the physician at that hospital. They will present that case, and they'll say, we've done this and this and this, and we're really at the end of what we can do. Yes. And if we all feel that the right thing is to put that patient on ECMO, we will deploy a team to that area put that patient on ECMO, and with the help of EMS, transport that patient back.
Yes.
And so what that looks like is that we would have at our center here, typically a surgeon or a cardiologist, a first assistant, and a perfusionist. A perfusionist is the person who runs the heart-lung machine. We gather here at CMC. We get 2 big bags that have all the equipment that we need, yes, and the machine. We get transported to that patient's location, yes, and that location can be an ICU, it can be an emergency room, it can even be in a floor, a cath lab, an operating room. Yes. We go to that hospital, we place that patient on ECMO. Placing that patient on ECMO means we put a cannula in the artery or the vein on both sides. We activate the machine, we stabilize the patient. Once that's done, we're in a position to transport the patient back. Right. We don't keep patients on ECMO at those centers. Yes. That is an expertise that we have nurses here that are trained on how, yes, to do that. We have an ICU that's, yes, trained on how to do that. So in general, that's how our ECMO and our shock program works.
Well, that's wonderful. I was just going to ask you, it seems like we are following the mission of the organization, which is one of it is a healthy community. Yeah. So we want to make sure that we are offering the cutting edge, the end stage devices, in this case ECMO, yeah, to our patients that need, no matter where they are within our system. Yeah. Now once you give them the device, you will then transfer the patient here to manage the patient, as many of these patients have to be on these kind of devices for a few days, sometimes for weeks. Yeah. I'm sure our EMS folks are also aware that they transfer a lot of patients with Impella. Yeah. And we work together. Do you want to also comment how we work together in regards to sometimes we put Impella to get the patient here, yeah, and then we get the patient on ECMO and those kind of things?
Yeah, so Impella and ECMO are different forms of mechanical support. Yes. And the beauty with an ECMO circuit, for example, as opposed to an Impella, is that you have the capability to oxygenate somebody. Yes. So you can actually, if you're not sure about their lungs, you can actually take that over. And it really, if you put somebody on veno-arterial ECMO, you're putting them on a heart-lung machine almost, yes, where they, even if their lungs and their heart don't work at all, they're okay. Yes. But for a lot of patients, they don't need that much support. Yes. They need something like an Impella. Yes. And an Impella, we see it all the time in our cath labs across the UH system. Yes. Somebody will come in with a big heart attack, you put in a stent, the stent is working well, but by then their heart's so weak that they can't pump by themselves. They don't need ECMO or oxygenation, they really need just help with their heart. Yes. And that's where the Impella device will go in. Yes. And just like ECMO, and a lot of you and your colleagues put the Impella systems in, and it's really put in usually through the femoral artery, typically, yes, and it goes into the heart, and it's a machine that sucks the blood out of the heart and puts it back into the aortic side. Okay. And that allows for 4 or 5 liters a minute sometimes, yes, and sometimes you only need 2 or 3 liters just to stabilize that patient. Once they're stabilized, usually we'll bring those patients, yeah, to CMC because they require a lot of care.
Right.
Yeah.
I think the one part that we should maybe highlight, and you mentioned it a couple of times, is our shock program, yeah, which is nationally renowned, honestly, because we have created a multi-specialty, multidisciplinary team of experts that get on the phone call at any time during the day. It could be 3 a.m. in the morning or 4 p.m. in the afternoon, yeah, and discuss the case and make decisions in regards to what's the best care for that patient, what's, yeah, the best thing we can do. And I think that's something that we are trying to also apply to the COVID era.
You know, and I think I'd go beyond that. What's unique to UH is that there are few places in the country doing that. You know, I worked at Harvard in the Boston area. There's nowhere in Boston that is doing anything, yes, like that. I worked at Stanford in California. Yes. There's nowhere in California that's doing anything like that. Yes. So what we are doing in Cleveland is quite unique. There are a couple other scattered areas, but the fact that we can go 50 miles away, put somebody on ECMO, stabilize that patient, and bring them here, I think you're right. It goes with the UH mission, which allows people to get care central to where they live. They don't always have to come to us, that's and right, we can go to them. Right. And sometimes that's it's a unique model, but it's been, I think, a really good model yes, for patients, and I think for us to do the right thing.
That's wonderful.
Yeah,
that's wonderful.
So in terms of getting back to ECMO, so in terms of clinical criteria, I want to show you a little bit of the rationale or why we would put somebody on ECMO, some of the indications and contraindications, and then to share with you a little bit of our triage workflow. And we've also, in this COVID area, we've also been working with our colleagues at the Cleveland Clinic in case we get into a surge capacity, in case we have so many patients on ECMO in the Cleveland area, and how we would do that, how we would work together. Yes. And I think it's been a good collaboration with our colleagues.
Wonderful.
So in terms of rationale, this is a little bit of what we were talking about before. So why would we put somebody on ECMO? And we're going to transition now a little bit more to COVID. So we know that most patients with COVID will be recovering and will be fine. Major epidemiologists from Johns Hopkins are telling us that case fatality rates are probably going to be 0.6%.
Yes.
It's not what we're seeing now. We're seeing case fatality rates of 4 or 5% in the U.S., but the reality is that we're not testing a lot of people.
Yes.
And we know that, for example, a study just came out yesterday, 10 to 15% of people have COVID and don't know it.
Yes.
And so when all is said and done, I don't think the case fatality rate is going to be as high as what we're seeing now.
Yes.
So most will recover, but some don't recover, and the reason they don't recover is that their lungs fail. They go into an ARDS.
Yes.
They go into their lungs white out. They can't oxygenate. They can't breathe. Their other organs may be okay, but it's primarily their lungs. They're also getting some cardiac side effects, but mainly it's been the lungs. When conventional therapy fails, so what is that? We oxygenate them. We give them now certain antiviral medications. Hydroxychloroquine is being tested and tried. IL-6 inhibitors. When they fail all of those things, they go on to mechanical ventilation.
Yes.
A lot of them will stabilize on ventilation. They're usually intubated for a while.
Yes.
They're usually ventilated for 7 to 14 days is what we're saying. But some of them will fail.
Yes.
Some of them, even on a ventilator, cannot oxygenate enough.
Yes.
And for some of them, that's when we get called. So right now in the COVID era, I would say every 2 to 3 days we're getting some form of a shock call right now.
Yes.
That somebody at one of our hospitals in the UH system is failing.
Yes.
We get on the phone, we discuss the case, we have an algorithm for, have you done this, have you done that, have you done that? And if they meet those criteria, then we may think about putting them on ECMO.
Yes.
And we know that some of the ones that, if you're young and you're otherwise in healthy shape, that may be your only chance to survive. And I think we need to give certain people that chance. And so as I mentioned before, we are coordinating our efforts with other hospitals, notably Cleveland Clinic, and we're trying to get to these patients at the right time.
Yes.
And we've tried to stress the message, let's activate this shock call when the patients are still viable and they're still okay. If we're waiting until they're in full-blown cardiac arrest or until they've developed kidney failure or liver failure, it's too late. So the process of who might need ECMO has been the source of a lot of discussion over the last few weeks. Major organizations have come up with criteria. The criteria that are widely adopted right now are through ELSO.
Yes.
And that is really, this is what that algorithm looks like. And let's go through a little bit just because I think it's important to kind of understand. So number one, you would treat the cause of respiratory distress syndrome. You would treat them, you would do all the things that they need to do. If we go down onto the left-hand side over here, so if they are needing a lot of oxygen to maintain a basic oxygen level, we would go down the path. What was strongly recommended is that we prone them. What is also recommended that you paralyze some of these patients. You use a high PEEP strategy. You can consider different types of things like vasodilators, recruitment maneuvers, other medications that are now being tried. But if they start to meet these types of criteria, that they're on 100% FiO2, they're saturating at low levels, their PO2s are very low, then at that point you have to activate the shock call.
Yes.
At that point we get on, we say, are there any contraindications to ECMO? And we'll touch on some of those in a minute. And if there are major contraindications, we say, look, no, it's a huge resource to deploy. It's going to just cause suffering for this patient. Yes. There's no hope really of getting that patient back. But if you're a patient like we had a couple weeks ago, there was a good reason to put him on. We put him on ECMO for 3 or 4 days. Yes. After 3 or 4 days, his lungs improved enough that we could take him off ECMO. Yes. Then I think you have a viable patient.
And that was a good patient, actually. That was an example of a patient that actually came in with a heart attack.
Yes.
Ended up getting a stent and getting treated, but then later on ended up having COVID, and we were able to advance the care, as you pointed out,
yeah.
and to try to kind of shepherd them through this acute illness.
Yeah. What has been really difficult is trying to figure out, this is through world experience with South Korea, Italy, yes. France, the US, in which cases should we do it and which should we yes. not? So we have developed what are absolute contraindications, so people yes. that are DNR, people who have a terminal diagnosis obviously already, neurologically devastated patients who've had a major stroke, end-stage heart or lung disease that was pre-existing. Yes. If they've been on a ventilator for more than 7 days, it's very unlikely that by putting them on ECMO, you'll reverse it enough yes. to get them off the ventilator. Liver disease, age, and multi-organ failure. And then there are relative ones, so they're not absolute, but if these patients have these types of things, we're going to really think about whether or not that's the right thing. If they can't be anticoagulated, if they've had a brain bleed, things like that, if they will not accept any blood products, for example, because we know these patients will likely need blood, if they're extremely frail, if they're in septic shock from other things, if they've got severe metabolic acidosis, those are all cases that we wouldn't say absolutely no to,
Right.
but it would have to be a good, viable patient for us to put them through this.
Absolutely.
And then what happens here is this gives you a bit of a schematic of how we do that. So again, patients are sick. The physician then calls our transfer center.
Yes.
The transfer center activates a COVID shock call. So on the line will be a cardiac surgeon, an ICU attending, a referring MD, oftentimes an interventional cardiologist. And then we'll have a discussion about that patient. We'll make sure that the contraindications, that the indications are there, the contraindications are not. And if we accept that patient, then the next question we have, and this pertains to our EMS colleagues, is are they stable enough for transfer? And what we are seeing with these patients is that a lot of them are not stable enough for transfer. They're having a lot of respiratory difficulty. They're on max ventilator settings. And almost every call we've had, and we speak to the ICU attendings, and they're like, no, we cannot move this patient. Some of them, if we get called early enough, they are stable for transfer. And what they become is they become a COVID patient who's highly contagious, who has to be transferred very, very carefully with a very tenuous respiratory situation. Ideally, if they're good enough to be transferred, that's probably the best, because we bring them directly here, we put them on ECMO here, where we have full capability. Anything that could go wrong, we can deal with it here. And if that's the case, they get transferred here, they get brought into the ICU, and we meet them at the ICU bed, and we'll have certain physicians that'll be there and place that patient on ECMO. If they're not stable enough for transfer, then our ECMO team is activated. So as I mentioned before, we have a surgeon, a first assistant, and a perfusionist. We all meet here in the lobby. The perfusionist and the first assistant get the bags that we need. Those bags have everything that we need to go to any hospital and put somebody on ECMO. It's fully self-sustainable. Gowns, masks, face shields, cannulas, wires, all the things that, I mean, you give a course on this, so a lot of the things that are taken from your course. And we're able to go there at the bedside, place that patient on ECMO. We have everything protocolized so that we hopefully get everything set up. We make one entry into that patient's room, which is a highly contagious room, do what we need to do, stabilize that patient, activate ECMO, and then once we do that, work with our EMS colleagues to then transport that patient. The transport with ECMO is obviously a bit tricky because there's a machine, there's a console, there are big tubes that are the size of my thumb that are coming in and out of that patient. So you have to move them very slowly, but we've done it many, many times, and it's usually pretty successful. So,
well, wonderful. You know, that was a great overview, Mark, and it really highlights the commitment that you and your team and UH has made to taking care of the patients here in Northeast Ohio. I guess my question to you is that, you know, how do you protect yourself and the team? You mentioned some measures, and you know, how do you make sure that you have enough surgeons available and interventionalists and others to be able to take care of these patients? Luckily, we didn't get a surge, but how are you planning that?
So we have a call schedule, a call rotation. We're trying to make sure that not all cardiac surgeons, just like not all cardiologists would be comfortable doing this. So we make sure that these are people that are trained, that have either done a course, that are used to doing this. So that's the first thing that we do. We want people to go into that environment comfortable with what they have to do. And the reason that that's important, at one point we talked about, you know, could an ICU physician, for example, do this? Because really it's like inserting two big femoral lines.
That's right.
And technically, absolutely, that person could do that. But to put them in an environment where they're not comfortable, I think would be really the wrong thing for that person and that team. So that's number one. Number two, as with all of our COVID patients, we have to adhere to the strict rules of how we get in and get out of that room. There's a spotter who's watching you don everything on. Number one. Number two is, even before we get to that stage, we have a list of all the things that we need to have ready, have it on a table, covered so that you can wheel the table in. It has everything on there. What you need to do is to make sure that once you enter that room, that you don't open that door unless absolutely necessary. So as you know, sometimes we do stuff in the ICU and, hey, I forgot this, or can you get me a line or this? We want to avoid that if at all possible. So hopefully when you enter that room, you've got everything that you need so that you don't need to open that door again until the team is leaving. So those are really the things that we've done. Fortunately, we haven't had to put too many patients on ECMO yet, but those are the procedures that all ICUs are following and that we're obviously going to be following for this. Yeah.
Well, I appreciate you taking the time to explain the role of ECMO, both the VA ECMO, which we typically use for patients with cardiogenic shock, as you mentioned, and also the VV ECMO, which we are offering to patients with COVID or other respiratory conditions. But also, I think you highlighting our integration, our commitment to our community and across our system, and the fact that we have created these protocols that actually others are using. So your role nationally and your group to educate others. I know we did a webinar together and you were able to inform thousands on how we do it here at UH. So I'm really proud to be working with you, and thank you for being at the forefront of taking care of these patients, and thank you for sharing your time with us.
Thank you, Mehdi.